Hello, everyone. Thank you for joining today's webinar. We are still waiting for more colleagues to join us, and we will start shortly. So just relax a bit and we can wait. Hello, everyone. Thank you for joining today's webinar. We're still waiting for more colleagues to join us. So just wait a bit. We will start shortly. All right. Good afternoon, good morning, and good evening to everyone. We welcome you all, particularly those of you joining from far away or at late or early times. Thank you for joining this WHO EPIWIN update on influenza, COVID-19, and other respiratory viruses, focusing on the winter season in the Northern Hemisphere. For those new to EPIWIN, this is the WHO Information Network for Epidemics for Science and Knowledge Translation in Health Emergencies. Our goal is to translate science in accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergency preparedness and response. Today, we have a great panel of experts to discuss updates on influenza, COVID-19, and other respiratory viruses. My name is Lester, and I will be hosting today's webinar. Before we proceed, here are some housekeeping and reminders. This webinar is being live streamed on the EPIWIN YouTube channel. The webinar is being recorded, and afterwards, the recording will be available from our website. The address will appear in the chat. We invite you all to post your name, location, and organization in the chat box. We would love to hear where you are joining us from. And I think many of you have already written their names in the chat box. Also, please add any questions you may have to at the Q&A box, not in the chat, so we can more easily keep track of them and provide some responses. All comments should be relevant to the topic and positive as much as possible. So please avoid negative, rude, or disruptive comments. We can remove you from today's webinar as participants if we find disruptive comments. Moving on, as in previous webinars, we want to know more a bit about you. And we also want everyone to participate and as we are preparing for this topic. We will have a short Slido survey now, and I turn over to my colleague Supriya for this very easy and quick question. Supriya, over to you.
Thanks, Lester, and hello, everyone. As we have a webinar today on respiratory viruses, we thought we'd like to know whether you've had symptoms of a respiratory infection in the past few weeks. And it looks like you have. Well, okay, let's just wait for a few more answers. Please join us at slido.com, hashtag 2125210. It's also in the chat. Slido.com, hashtag 2125210. Yeah, we've had about 70 or 77 responses, and looks like well, it looks like 50-50 so far. Many of you have, and many of you haven't. So this will be on, the Slido will be on. You're welcome to respond to it whenever you like. But in the interest of time, I now hand the floor back to Lester. Over to you, Lester.
Thank you, Supriya. Yes, around 50-50 of us have had symptoms of respiratory infection in the past few months. And thank you so much. And without further ado, we move on. I'll now hand over the floor to Dr. Maria von Kerkhoff for the welcome and opening.
Thanks, Lester. Hi, Supriya. Hi, everyone. Thanks very much for joining this EPIWIN seminar today. I'm going to be very brief because you're going to have some very good presentations and hopefully quite a bit of time for Q&A. I just wanted to say a couple of different things. There's a lot of attention right now on respiratory diseases, and just from that survey that you just took, many of you are experiencing respiratory diseases, but maybe many of you don't know WHO's really critical role in working with all member states, working with all countries, in fact, partners, public health institutions, academic partners, WHO collaborating centers, even the private sector, on making sure that we better understand and assess the circulation and public health impact of respiratory pathogens, mainly viruses, including flu, including SARS-CoV-2, MERS, RSV, but we also are monitoring the health impact of some bacteria as well. It's really critical that all countries are contributing to surveillance and that they're sharing information about the circulation of these pathogens. It's essential for us to work with partners around the world to assess the risk, to detect any unusual patterns, and for information sharing across public health institutions, and to guide our public health responses. WHO relies on the timely sharing of this information from all countries, from our member states, but even beyond, to monitor virus evolution and its impact on health systems. We conduct risk assessments and we develop policies, again, together with many partners. The data that's gathered through surveillance systems supports WHO conducting risk assessments, but also in developing evidence-based guidance and updating our policies to protect public health. This is a dynamic system. We are always learning. We are always gathering new information and using that information to adapt our evidence-based guidance and our policies. The Global Influenza Surveillance and Response System, or GISRIS, which you'll hear more about, is a 73-year-old network. It has expanded to tackle multiple pathogens, including influenza, which it started with, SARS-CoV-2 during the COVID pandemic, and RSV. And this ensures a comprehensive understanding of virus circulation. There are some seasonal patterns that we see with some pathogens, like influenza. We do see some patterns with RSV as well. SARS-CoV-2 doesn't yet have a seasonal pattern, and it's been circulating now for 6 years. But these pathogens have peaks, and they have waves of infection that we've seen that have detrimental impacts on health systems. For COVID, we are transitioning from an emergency response, as we did during the peak of the COVID-19 pandemic, into a long-term plan as part of overall managing respiratory viruses. We want to acknowledge the contribution of countries who are conducting surveillance. We want to encourage more surveillance to be done, strategic, and the timely sharing of this information. This weekly sharing of information really enables us to monitor this virus, not wait and watch, but really actively monitor and detect any unusual signals. The focus today, you'll see, is on seasonal influenza, but there is a lot of attention on zoonotic influenza. You may have some questions about that later, and we've done some EPIWIN seminars specifically on zoonotic influenza or avian influenza. We encourage our member states and our partners to continue to invest in integrated respiratory surveillance systems that enable us to monitor virus circulation and evolution, as well as look at the impact on health systems and support our member states to manage that burden. There's a number of tools that are available from WHO and from our partners to control seasonal influenza, COVID-19, RSV, and other respiratory viruses, including vaccines, therapeutics, diagnostics, and the use of public health and social measures. So we use all of this information, we use the tools as part of comprehensive disease prevention and control programs. So thank you very much for all of you who are joining today. Wish you a very active and dynamic EPIWIN, and I pass it back to you, Lester.
Thank you, Dr. Maria Van Kerkhoff. Thanks for giving us an overview of WHO's role in surveillance, the role of countries, and the comprehensive approach of this sector in surveillance, in monitoring, and the different tools and actions. So we're looking forward really to hear that. Thank you so much. So we now may call on Dr. Wenqing Zhang, who is the head of the Global Influenza Program. She will be introducing also the next speakers and the presentations. And I turn over the technical facilitation to her. Over to you, Wenqing. You're on mute, Wenqing.
Now works?
Now,
Great.
yes. Thank you.
Thank you so much, Lester, and thanks to Maria for the opening remarks. I would like to add my welcome to everybody to join this WHO's EPI-WIN webinar on influenza, SARS-CoV-2, RSV, and other respiratory viruses. This webinar will comprise 3 short presentations, which will be on an update of influenza, SARS-CoV-2, RSV, and other respiratory viruses. And it will also include the metapneumo, because there's already a question asking about that. Afterwards, we'll have a panelist for Q&A. For the panelists, aside from the 3 presenters, Professor Maria Zambon will also join in the panel. So let's move on without further ado to the first presentation by Aspen Hammond from the Global Influenza Program on influenza and RSV. Aspen.
Thank you, Wenqing, and thanks everybody for being present. As was mentioned in the opening, I'm going to focus on a brief update on influenza activity and a few slides at the end on RSV activity. Next slide, please. And from the Slido quiz, I guess a lot of people have already had symptoms. If you haven't yet, seems activity is still continuing in many areas. So take care of yourself. There's still a lot of viruses circulating. What I wanted to start with is just an overview of WHO's approach to influenza surveillance. It's a very old and experienced system, a global system called the Global Influenza Surveillance and Response System that's existed for over 70 years. The threat of the global threat of influenza was recognized back in 1952, and the system was set up to collect and characterize influenza viruses detected around the world, as we know that these viruses can cross borders and infect and spread around the world. So currently, we can see the map of the current system of GISRs, where we have over 150 national influenza centers in around 130 WHO member states. We also have 7 WHO collaborating centers, which do further in-depth characterization of influenza viruses. There's also 4 essential regulatory labs, and we also have 12 H5 reference labs. So it's with this system that we're able to really have a close eye on the circulating influenza viruses and their characteristics. And just to show how many influenza viruses or how many specimens are tested for influenza viruses each year, the graph on the right, you can see over the cumulative number of samples each year is in the range between 8 to 12 million over the past few years. So it's quite a lot of samples tested. And all of this effort is really thanks to enormous commitments from member states, and also support from international agencies and partners to be able to test and share a lot of this information on influenza. Next slide, please. And so the topic is really to focus on the activity in the northern hemisphere of the globe. So this chart shows an extract of influenza detections from the GISRS network that are reported to WHO's data platform for influenza called RespiMart. So this shows the detections over time since 2020. And the different colors in the columns indicate the different kinds or subtypes of influenza viruses, with H1 shown in light blue, and the medium blue is the H3, and the darker blue-green as A viruses, where the subtype has not been determined, and then the orange colors are the influenza B viruses. So we can see, I think it's important to note from this that influenza activity is seasonal, as was mentioned, and has returned to this seasonal pattern following the pandemic, and has returned to levels that we saw before the COVID-19 pandemic. Next slide, please. And this slide is just to take a little bit closer look over which viruses are circulating over the past few months. So now this is just selecting the detections that have been reported since October of 2024, so over the past few months, again in the Northern Hemisphere on the left side, and in the Southern Hemisphere on the right side. So we can see that in the Northern Hemisphere, that H1, among the influenza A viruses that have been subtyped, H1 is predominant, again, in the Northern Hemisphere over the past few months, although there are detections of H3 and B viruses as well. And in the Southern Hemisphere during this period, activity is fairly low, as would be expected, but there does continue to be detections reported of predominantly influenza B viruses. Again, that's in the Southern Hemisphere over the past few months. Next slide. And this slide is to give a bit of a closer look at different trends in different geographic regions in the Northern Hemisphere. So here I've taken some of the same charts of influenza detections that have been reported since October 2022, so over the past few years. Again, looking at those countries in the Northern Hemisphere and looking by region. So we can look at, for example, the top left chart shows the activity and the trends in Africa and the regions in Africa. We can see that over the past few months, there has been sustained influenza detections reported of a variety of subtypes, all influenza seasonal subtypes, but with H3 predominant. And then in Asia, we can see that the H1N1 viruses, again, that's the light blue color, have been predominant over the past few months, although activity seems to be on the decreasing trend in Asia. In Europe, on the bottom left, we can see, again, activity remains quite elevated, again, in the seasonal pattern. There are a lot of influenza unsubtyped viruses, but of the subtyped ones, again, H1 is predominant. In North America, that's on the top right, we can see that activity has been elevated over the past few months. Again, a lot of the viruses, the subtype is not determined. That's just part of the laboratory process. But again, it looks like H1 is predominant in that region as well. In Central America and the Caribbean, again, in the Northern Hemisphere countries there, we can see, again, an increase in activity over the past few months with H3 and H1 co-circulating. And there's a few countries in tropical South America that have had and reported increased activity again with all the influenza seasonal virus subtypes reported. So H1, H3, and influenza B viruses. So again, that's just a bit of an overview of activity by geographic area. If you go to the next slide, please. This just zooms in a bit on the most recent information, the most recent data. So the Global Influenza Program, we publish a weekly report on the global influenza situation, the seasonal situation. So this is just highlighting some of the information from the most recent report, where we can see in more detail activity and trends by country. And then we can also see, again, the breakdown of the influenza subtypes, types and subtypes by geographic region on the chart on the right. So I'm not going to go into detail on these charts, but the link is here and will be shared in the slides. Again, we do publish this weekly report, which can give you a bit more information on where exactly influenza is elevated, where it's increasing, where it's decreasing, and which viruses are predominant in which area. Next slide, please. And then I just have two short slides on RSV activity. There in the region of the Americas, there is quite a lot of surveillance and detections of RSV that are reported, and a nice report is put out by the regional office summarizing RSV activity in the Americas. So we can see that RSV in general in the region reached levels comparable to previous years in terms of the seasonal patterns. Appears to be declining in North America, and is also continuing to decline or remain low in other subregions. And RSV epidemics, again, we can see this seasonal pattern that's returned since the pandemic over the past few years. Next slide. And the next slide shows similar information, but coming from the WHO European region. The charts on the right give some indications of the co-circulation of influenza, RSV, and SARS-CoV-2, and in primary care, so in general practitioners on the top, and on the bottom is in hospital surveillance or secondary type care. So in that region, we can see RSV positivity in the primary care remains at sort of a moderate level, but is sort of plateaued over the past few months, peaked a bit earlier and at the end of 2024. And again, it's really affecting children under 4 years of age. But again, seems to be plateauing in that region. Next slide. I'm just going to finish up just again to share some of the resources coming from the WHO headquarters and the Global Influenza Program. We've published updated guidance on integrated surveillance for respiratory viruses at the end of 2024. So the link to that guidance with a lot more information on surveillance is available. And again, just to link to our weekly outputs on influenza and also SARS-CoV-2 that are available on our website. Next slide. So with that, I'll finish, and I just thank you, the audience, for your participation, and many thanks and acknowledgements to colleagues at the Global Influenza Program, as well as all of our colleagues working on this in WHO region and country offices. Of course, all the hard work that happens in the countries to get this surveillance done and viruses shared, and all the participants in the Global Influenza Surveillance and Response Network. Thanks very much.
Thank you very much, Aspen, and thanks for also keeping the time. So everybody, if you have questions, please type into the Q&A. There's a tab, Q&A. You can type in your question, but don't type into the chat because that will not be catched. Let's move on to the next presentation by Ais Akama from the WHO's coronavirus program here. She will give an update on SARS-CoV-2.
Thank you very much, Jing. Is my screen visible?
Actually, it's not. Now, yes.
Yes, and it's full screen, I hope. Okay. Thank you very much. Good morning, good afternoon. I will give a brief update on the situation of COVID-19. I will start with the circulation, as Aspen already gave a detailed description of the global influenza surveillance and response system for the circulation of SARS-CoV-2. We are using this system as well with the integrated surveillance of SARS-CoV-2. In this slide, we can see the circulation for the week ending on 9 February 2025. On the left-hand side, there is the test positivity rates coming from the countries from sentinel sites or systematic virological surveillance sites. What we see in the Northern Hemisphere, mostly in the Northern America, Europe, Western Pacific, and Southeast Asia, there is low activity of SARS-CoV-2, this is a trend since the end of the 2024. However, we see elevated activity in some countries still from Central and South America and Southern Africa. On the right-hand side, the map shows us the change in proportion of these test positivity rates coming from the countries. What we see is all countries show the stable or declining trend except one country from the Central America. But the main message, I guess, is the SARS-CoV-2 continues to circulate with other respiratory viruses. And in the next slide, what we will see that we have observed in the Northern Hemisphere from Europe and Americas, there was a prolonged elevated SARS-CoV-2 activity in summer months, which has not reflected in the surges in the cases in the Northern Hemisphere this winter, hopefully, as opposed to last winter. The seasonality, as Maria mentioned, that has not been established yet. We are yet to determine it and monitoring it. We are also monitoring the signals coming from the wastewater surveillance of SARS-CoV-2. There are some countries sharing their data publicly available in their epidemiological reports or dashboards. For the period between the week 3 and 6, which is mid-January to mid-February, there were 20 countries across 5 WHO regions had updated their information on wastewater surveillance for SARS-CoV-2. In line with the test positivity rates, the overall trend for the wastewater activity is decreasing to stable trends. However, we have captured some signals from the Northern America with the high level activity in wastewater and some increasing trends. Those trends have not reflected yet in terms of the test positivity rates or increases in hospitalizations. Wastewater monitoring for SARS-CoV-2 also can give insights for the distribution of variants of SARS-CoV-2 in the community. There were 7 countries who updated this information for the given periods. What we see is mostly higher XEC concentrations in the majority of the countries, while there is one Western Pacific countries showing the KP3 concentrations are higher. If we continue with the circulation of the SARS-CoV-2 variants, GN.1 and its descendant lineages remain the most reported SARS-CoV-2 variants. WHO monitors the SARS-CoV-2 variants and classifies them as according to their public health impacts. Currently, we are monitoring one variant of interest, which is GN1, which is showing a stable trend with a slight increase in the recent weeks at the 17% prevalence global level. We have 7 variants under monitoring are circulating. The predominant variant at global level is the XEC, which is showing a stable trend in the recent weeks. The recently designated SARS-CoV-2 variant LP8.1 is showing an increasing trend. However, all the other variants under monitoring are showing a declining trend at the moment at the global level. So WHO is undertaking risk evaluation for variants under monitoring and variants of interest with the technical advisor group for the virus evaluation. And the recent risk evaluations conducted for XEC and LP8.1 showed no additional public health risk in comparison with other co-circulating variants. But there are some regional variations in terms of the distribution of these SARS-CoV-2 variants. XEC is declining in Europe and in Americas, however, showing an increasing trend in Western Pacific region countries. Meanwhile, LP8.1 is showing an increasing trend in Europe and in Americas and Western Pacific region countries. LP8.1 also detected in one country in Africa, however, has not been detected yet in Southeast Asia countries or Eastern Mediterranean region countries, which might be due to the lack of enough samples submitted to global data. So when we look at the impact of the COVID-19, of course, it still continues to cause the severe disease and deaths. Although the numbers that we are seeing here is a likely underestimation of the true death toll. Since the beginning of the pandemic, as of 2nd of February, WHO has been reported over 7 million deaths. In the past 7 days, we have received 736 deaths by 11 countries. However, we have also some more reliable indicators to monitor the impact of COVID-19, such as on the right-hand side, we can see that deaths per 1,000 hospitalizations. What we see in these figures that we calculate this indicator from the countries who shares the data for both number of deaths and hospitalizations. And in April 2022, when it was in its peak, there were 169 deaths per 1,000 hospitalizations observed. This number is now, in early February 2025, decreased to 78 deaths per 1,000 hospitalizations. However, we should be cautious that this data was also limited to, for example, 59 countries who shared this data in 2024. Last but not least, I want to talk also about the COVID-19 vaccination uptake. It was been very low in 2024, and in September 2024, WHO Strategic Advisory Group of experts for the immunization has recommended at least one COVID-19 vaccine dose for who has never received one. But also periodic revaccination recommended for high priority groups and population with special considerations. An interval of this periodic revaccination is going to depend on the individual's level of risk. WHO Technical Advisory Group vaccination composition recommended retaining the monovalent GN1 vaccine composition. According to available immunogenicity data, GN1 vaccines do provide modestly enhanced protection, but all the pre-qualified or emergency use vaccine compositions are reasonably showing high vaccine effectiveness against severe disease and deaths. So vaccination shouldn't be postponed in anticipation of having an updated vaccine composition. COVID-19 and influenza vaccines are recommended for the same adult high-risk groups, and it should be recommended to having both of them. However, we see important disparities between regions of this vaccine intake and income groups. And the data on the right-hand side, that we see that in the older adults, for the first 3 quarters of 2024, the global uptake of the COVID-19 vaccines was less than 2%. And at the global level, the high-income groups showed less than 1% as well, and the upper middle-income group of countries showed 2% vaccine uptake. We have also some resources that I want to share lastly. Integrated surveillance guideline, as mentioned by Aspen, is also very important for surveillance of SARS-CoV-2, and we are also very thankful to member states for integrating SARS-CoV-2 into their routine surveillance within the agencies. In 2024 December, WHO HQ also published some policy briefs to help the member states and policymakers in various topics. One of them is surveillance, but there are also policy briefs created for and updated for testing, clinical management, vaccination, IPC, and risk communication and community engagement. WHO routinely conducts global risk assessments for COVID-19, and we recently published the last risk assessment for COVID-19, which we found to be high on the website. We also, as mentioned earlier, conducting regular risk evaluations for SARS-CoV-2 variants, and we're publishing them also in our dashboard and in the and the tracking website for SARS-CoV-2 variants. We have also global COVID-19 dashboard, continues to update the information and inform the public, as well as we are publishing monthly epidemiological updates for COVID-19. The COVID-19 vaccination insights reports also can be found in the given link on this. Thanks a lot. Over.
Thank you very much, Ais. Okay, wonderful. Let's move to the last but not least presentation on other respiratory viruses by Ben Cowling. Ben.
Thank you very much, Wenqing. So my pleasure to share just some relatively brief remarks on other respiratory viruses. The first thing I would like to say is that there's a lot of confusion between common colds and flu. And certainly when I was young, my mother told me that if I just have a sniffle, if I have a cough, maybe it's just a cold. But if I've got a fever, I need to stay in bed for a day or more, then it's the flu. Actually, what we recognize now is that many different respiratory viruses can cause very similar symptoms. In some cases, just mild respiratory symptoms. In other cases, something a bit more serious. And that can happen with flu. It can happen with SARS-CoV-2 now, as we know in the last few years. And it can also happen with a variety of other respiratory viruses. So almost any respiratory virus will typically cause milder symptoms, and in some more unusual cases, more rare cases, will cause more substantial disease. In the United States, I got this from the website of the US CDC yesterday. So there's still surveillance data from the US, thankfully. We can see patterns over time in many different respiratory viruses in terms of the percentage of respiratory samples that test positive. And there's different colors representing different respiratory viruses. I highlight influenza in the top right, which has been increasing with the flu season. Rhinovirus in gray, which is always around, is probably the most common cause of coughs and colds. There's many, many different serotypes. You can get rhinovirus again and again and again. And some children seem to get different rhinoviruses in different months quite often. And then in green, we have RSV, and then the other lines are other viruses as well. Red on the left-hand side of the figure is SARS-CoV-2 that was higher before, now is lower. So we can see there's a constellation of different viruses causing acute respiratory illnesses. In the United States, this is just one constellation. If we were to look at similar data from Europe, from Asia, there would be a mix at any given time. We have to be careful that when we look at the lines on this graph, just because the lines are changing over time, it doesn't mean the burden is changing in proportion to those, because this is just the laboratory tests that are being done, and there tends to be more tests done in the winter than in the summer and so on. Nevertheless, we can get an idea of some of the patterns. So I'm going to come to human metapneumovirus in a moment, but I just want to make a brief comment while I have the opportunity on RSV vaccines, which Aspen didn't say much about earlier. So in some locations, RSV vaccines are now available for older adults, not everywhere in the world, but as time goes on, I suspect there'll be more availability and more countries choosing to use them. And there's very exciting data just reported last week. I think it's very exciting, from Scotland, showing a clear impact of RSV vaccination in the target group of 74 to 79 years of age individuals. So the 2023 data on the left-hand side of this figure is before they implement, and there's basically a straight line. And then in 2024, after the program's implemented and there's a certain degree of vaccine uptake, there's a clear reduction in RSV disease burden in this particular age group. The vaccine uptake was 70%. There was a 62% reduction in disease burden, and that matches what we expect with 80 to 90% vaccine effectiveness. So it's very encouraging. I think other parts of the world are going to look at this and see that they could also consider using RSV vaccines to reduce disease burden in older adults. Now, human metapneumovirus has had a lot of attention in the last few weeks, the last couple of months. Where I am in Hong Kong, there's a lot of talk about HMPV and what's happening. And so firstly, I'll just explain what it is. It's one of many respiratory viruses that cause acute upper respiratory infections. Usually it's mild. Sometimes it can be more serious. It's a relative of RSV, which we've heard more about today. It was first identified 25 years ago, but it's been around for a lot longer. It just wasn't known before then, but it's been around for a long time, and it spreads in a similar way to the other coughs and colds. So there were reports in the media of high levels of HMPV hospitalizations, but actually on a closer look, it didn't seem like anything unusual. And in the figure on the right, I'll share unpublished data from Hong Kong, where we monitor what's going on in hospitals with children admitted to hospital, what's the virus, if any, detected in those children, and all the different colors are all the different respiratory viruses. And I highlight in red from 2018 up until now. 2017, we weren't testing for HMPV. 2018 until now, red is there, but it's not a lot. It's a low amount, and it tends to pick up in Hong Kong, maybe March, April, May. And so I guess there'll be another wave coming soon, but it's not a large wave, not like flu that really puts a lot of pressure on hospitals, or COVID that has done it in the past. But winter surges will be expected in a variety of respiratory viruses. I don't think HMPV it's a concern, but it's not the biggest concern, I guess, at the moment. I think for me, flu would be the one to really keep an eye on this winter, and of course, COVID. Now, I'm getting to the end now, and I just want to also make some remarks about control. We've heard a lot about surveillance, we've heard a lot about health impact, but there are options for control. We have vaccines for influenza, for COVID, and for RSV that we've heard about. The availability varies for different vaccines in different locations, but there are vaccines at least for those pathogens. For other respiratory viruses like HMPV, like rhinovirus, like the others, we don't have vaccines. So the only way that they could be controlled would be through non-pharmaceutical measures. If you ask me or other experts maybe 5-10 years ago, how effective would these NPIs be on other respiratory viruses, we wouldn't completely know. We'd think maybe it would do something, but there'd be sometimes a perception that they wouldn't have a large impact. Now we know differently. From the COVID pandemic, we know that non-pharmaceutical interventions can have a drastic effect on other respiratory viruses. I show a publication here from Hong Kong that I was involved in, but you can search online, you can find papers from around the world during the COVID pandemic where respiratory viruses were almost absent, and that was whether there was somewhat public health measures or stringent public health measures, whatever. In general, non-pharmaceutical interventions can have quite an effect, although we have to recognize they can be costly and disruptive. So I don't think we would use them all the time, for sure. And some places would be quite against the idea of using them in general. But if there's a lot of pressure on hospitals, I think that there may be circumstances where we might think about them, at least in some parts of the world, at some periods of time. And then the last comment, self-isolation continues to be recommended. Keep your cold to yourself, I put on the slide. So if you've got an acute respiratory illness, whether it's flu or COVID or another one, keep it to yourself. If you do need to go out, you can't stay at home, wearing a mask, I would certainly recommend as a simple precautionary measure that, again, 5 or 10 years ago, we wouldn't maybe think too much about. But now with the COVID experience, a lot of us have had experiences of wearing masks, and we may even have some masks left over from COVID. So that's my recommendation. And there I will pass back to the chair. Thank you very much.
Thank you so much, Ben. So with this, let's move to the Q&A now. And I would like to invite all our panelists, please switch on your camera so that we can see you. And for participants, please type your questions under the Q&A button. Before we open for Q&A, I would like to invite Maria Zambon from UK HSA. Maria, I think you can only have 2 minutes now. Would you be able to give an update of the non-flu, non-SARS-CoV-2 virus circulations in UK? Maria, you're muted.
Apologies. Thanks very much, Wenjing. Since A's, Ben and Aspen have done such a great job on discussing non-influenza viruses generally, I have relatively little to add about the situation in the UK, but I would add again on the metapneumovirus situation, because there's been a lot of talk about this it is worth putting into context, exactly as Ben has done, what we have seen. So we have monitored human metapneumovirus for the last 20 years, literally from the time that it was actually first discovered. And we definitely have not seen anything unusual in human metapneumovirus this year. And I think that's an important sort of general consideration. Secondly, in relation to SARS-CoV-2, I think we are starting to center on what we think will be is our SARS-CoV-2 circulation period, which looks as though it is sort of July to October. We observe when we have influenza circulating, we have low circulating SARS-CoV-2. And for us, RSV tends to be at a fixed time every year, November and December, and doesn't always coincide with influenza. So this year we have seen a pattern of RSV first, then a peak in influenza, and we're coming out of the peak of influenza. My final remark is I absolutely echo Ben's comments about rhinovirus, because when there is a broad respiratory viral surveillance, probably the most frequent detection is actually rhinovirus, whether that is in a community surveillance program or, surprisingly, in a hospital-based surveillance program. And I'll stop there. Hopefully that's within the 2 minutes. Over.
Thank you so much, Maria, for this insight. Okay, so actually we do have quite a lot of questions, and I will try to group them to the panelists. Maria, maybe we start with you now that you are on the microphone.
Okay. Yeah, what was the first question? Sorry.
Question about children. Why children are susceptible to certain strain, and why, for example, RSV, the particular burden, why the particular burden is with the children? Do you have any insight?
Well, RSV has the greatest burden in the youngest age group when there is least immunity and when the airways are particularly narrow. As children grow, the kind of pathogenesis associated with RSV becomes progressively easier to deal with, along with the acquisition of immunity. But the most susceptibles are the very youngest children in the sort of 0 to 3 months age group. And I think that would be the starting point. But like other respiratory viruses, the peak, the sort of most affected ages are the very youngest and the very oldest. And it is indeed very good to see that vaccination programs in the elderly are going to help with this very under-recognized impact in elderly populations. I'll stop there, see if others have got anything to add.
I don't know if, Ben, you have anything to add specific about children.
No, I mean, I think when we think about the age pattern in respiratory infections, children are always there. That a lot of these respiratory infections have a high burden in children, with more transmission in schools, with maybe less immunity, and until people have the infections and better immunity. It's COVID that stands out as something unusual, where there hasn't been as much COVID in children, at least severe disease. There is some, and I showed on my slide with hospitalizations, there is COVID detected in children as well in hospital, but it's not as much as maybe we might have expected if we were basing on what we know about other respiratory viruses. So I don't have an explanation for that. Ever since the start of the COVID pandemic, there's been a lot of questions. Why aren't we seeing more severe cases in young children compared to what we see with other respiratory viruses? So I can't answer, sorry. Still a bit of a mystery to me, at least.
Thanks a lot. And of the circulating influenza virus strains, actually influenza B, we can see a lot of hospitalized children infected by influenza B strain. Okay, let's move on. So again, come to Ben. Again, you're on the screen now about using masks, and also public health social measures. Do you have any comment on that?
Yeah, so the study that I cited in Nature Medicine, where I'm the senior author, we looked at the effectiveness of face masks in reducing emission of viruses from people with different kinds of common colds and flu as well. And masks were very capable of blocking those respiratory viruses. So as source control, I think masks will have a very good effect. And if there's someone out there who's got a cough or a cold, but they need to go to the pharmacy, they need to go to the supermarket, if they wear the mask when they're out and about, it will definitely reduce, but not 100% prevent. It would definitely reduce the chance of spreading the infection in the community. Where there's been a lot of controversy is when there's been widespread mask use, and yet there's still been viruses going around in the community. And that's maybe over a longer period of time with compliance not always 100%, with masks not themselves being 100% perfect. They have an effect, but it's not a total perfect effect. That's where maybe we can't expect an absolute disappearance of every respiratory infection when there's widespread mask use. But on a personal level, I would certainly encourage people who are sick to wear masks to reduce the chance that they spread infection to other people around them. And I think there's a good evidence base for masks as source control.
Thanks, Ben. And from WHO, we're updating the guideline of public health social measures. And of course, that includes also using masks. Okay, let's move on. And I'll ask Aspen to take the question about this season. Is there any particular about the severity of this season in comparison with previous seasons? Anything unusual? Any comments on that about severity?
Thanks, Wenqing. Yeah, it's a good question. And we do recommend that countries can assess the severity of the current season using data from previous seasons, so putting the current season in context of what's been seen in the past, which is a good approach to be able to assess severity. And we receive some of that information from countries. There have been a few reports that this season is high in some countries in terms of the amount of syndromic illness, so the number of cases with acute respiratory infections and influenza-like illness, and also on hospitalizations. There's continuing activity in the United States, in Europe, and so activity continues to be elevated in those and is in line or very similar with past seasons, and in some is a little bit higher. But I don't think that it's excessively elevated over what's been seen in the past this year.
Thanks very much, Aspen. Okay, let's take a question about COVID. And I'll ask Ais to answer the question. Could you just comment about COVID vaccine composition and the recommendation on using COVID vaccines? Yeah, could you just give some comments on that? Thank you.
Sure. Thank you for the question. So the last meeting for EPIWIN, which is the technical advisory group who are determining the vaccine composition, and was in December 2024, and it makes these decisions by reviewing the available evidence and the data. Given the breadth of the immune response demonstrated by monovalent Gen1 lineage vaccine against circulating variants at the moment, TACOVAC continues to advise retaining the current COVID-19 vaccine antigen composition. And I will share in the chat the available link here, which will show it. But the TACOVAC convenes every 6 months and continues to review the available data. And the next reconvening will be in May 2025 to consider if there's a update necessary for the vaccine composition.
Thank you very much, Ais. Okay, let's move on to another question about the wastewater surveillance and how the data could be used to predict the virus circulation, etc. Maybe Maria, would you want to start?
Not a nice question to be able to answer. Wastewater surveillance has got some great capabilities. One of the most difficult things, though, is working out what is the relationship between what you detect in wastewater and a number of cases that you actually have in the community. So the absolute strength of wastewater is looking for really rare and unusual things. A good example would be polio. So it's really excellent for things like that. For prediction of variants, I think that's quite tricky. And I don't think we've got the capability yet to know how to interpret the signals that we've got for circulating respiratory viruses about what are going to be the most important circulating variants. Now, others may disagree with me, but that at present is my perspective on this.
Other panelists want to add on the wastewater surveillance question?
Maybe I can add that for SARS-CoV-2, at least we use it as a kind of early warning system. Still, this system needs optimizations and lack of standardizations. However, it is kind of showing us, especially when there's the clinical data is lack, but there is the wastewater surveillance it gives insight of the circulations.
Thank you very much for this addition. Okay, let's move to a next question. Is about surveillance, how we are going to evaluate, how we are evaluating national surveillance, and whether the lack of surveillance will impose any risks on the global health security, etc. Maybe Aspen could start, and then I'll invite others to comment.
Yeah, I think it's really important. This is really the underlying concept of the international health regulations that every country should be able to detect something unusual and investigate and report that. So we don't know where the next pandemic virus will emerge. So it is really important that everybody is doing some type of surveillance and has a rapid response mechanism to whatever may happen, and can share that information quickly with global authorities so that we can do the risk assessment and understand what needs to be done.
Yeah, also to add that for the evaluation, etc., for seasonal virus surveillance, WHO has the standards, published surveillance standards. For outbreak, unusual events, etc., WHO has an IHR core capacity checklist. So there are such standards available for countries to develop such a capacity in countries. I think I still have quite time for one or two questions, I guess. So let's move to ISV again, because a lot of interest actually on ISV vaccines. Maria, maybe you can add a little bit more comments about the current use of ISV vaccines, if you have any data, and whether the status of the ISV vaccine development.
Are you talking about data from the UK? I should say then that what we've done is we introduced RSV vaccination programs in 2 categories in the UK from September of last year. As you've already heard, there is emerging data coming from our elderly population where we've made a vaccine offer from those that are over 75. And we also have started on a vaccination campaign in pregnancy, which at the present has a fairly low uptake. In terms of development, I think there are a whole raft of approaches, including mRNA vaccines, which include influenza and RSV. And I think the future is reasonably bright for the development of new vaccines generally, but it's not without difficulties. The vaccination programs generally. There are also vaccinations or rather immunization programs involving the use of monoclonal antibodies, which look to be very effective. So I think we're at the start of a very exciting time in RSV interventions, and I'm sure others have got things to add to that generally.
Thank you so much, Maria. Okay, so I'll keep the last question to myself, maybe 2. One is about circulating viruses and whether circulating viruses so-called match the vaccine composition or not. So we do have a teleconference with all WHOCCs to have a review of the status of the circulating viruses vis-a-vis the vaccine composition in January. Yes, the answer is very positive. Yes, the vaccine, covers well the current circulating viruses causing diseases. Another question about the US, or many questions about the US. So just for everybody to know that the CDC has just released a lot of genetic sequence data last Friday in Gazette. a lot of seasonal viruses from US as well as from elsewhere. And CDC also has been updating their weekly the seasonal influenza situation, as well as update the zoonotic H5 avian influenza situation on CDC's website, as well as on the USDA website. But since 20th January, CDC has not yet reported to the WHO platform of FluNet and FluID, etc. Okay, so I think time is due for me to hand back to the chair to the chair. But thanks to all my panelists. Thank you so much for your participation and answers. Lester, back to you.
Thank you, Wenqing. Thank you very much, panelists and speakers. So we had a very good discussion and topics on the different patterns of respiratory infections, different regions, a lot of data there, seasonality. We also tackled about influenza, COVID-19, other respiratory viruses, and the different tools have been mentioned, tools for surveillance, risk assessment, capacity standards in countries, and also a lot of mention also on data sharing from different countries. We also heard a lot of updates on vaccines that are being tested. And of course, very practical advice such as the use of masks and other public health and social measures. So we are now at the end of our allotted time. Thank you very much. We want to say thank you to our speakers and panelists, and the WHO colleagues and the team that worked behind to make this happen, including the Global Influenza Program, the Emerging Diseases and Zoonosis teams, and our experts and panels. Finally, thank you everyone for coming and for active participation through the Q&A and through Slido as well. The recording of this webinar will be available at the EPIWIN website. An EPIWIN digest, a slide set with key messages on this topic, will also be published shortly. If you want to keep updated on future EPIWIN webinars, recordings, and presentations, and the EPIWIN digests, please subscribe to our mailing lists, which will be provided on the chat. And we hope that you will also join us for our next webinar. It will be next week, February 26, Wednesday, at the same time. 1 p.m. Geneva time. The topic will be on mental health and psychosocial support aspects of responding to public health emergencies, the why, what, and how. Details will be posted on the website and sent to the mailing list. So thank you all and goodbye, and see you next time.
Thank you.
Thank you.
Thank you.